Now, today we are going to look at mainly the drug treatment of Parkinsonism. As we have seen earlier, Parkinsonism here, clinically it is three important aspects. Four. Trap. What is trap? Tremor, rigidity, akinesia, and postural instability. So tremor, akinesia, bradykinesia, postural instability, and rigidity, whenever you see these people, with any one or more of them, you must evaluate for Parkinson's. There's no doubt about that. But remember, it's an iceberg. There are several symptoms listed here, like constipation, speech disturbances, swallowing disturbances, panic attacks, loss of smell, lack of facial expression, hypotension, impulse control disorders, delusions, sleep difficulties, bladder dysfunction, pains, depression, anxiety, gastric reflux, hallucination, sweating, dementia, erectile dysfunction. So name anything, most of the common medical conditions. The Parkinsonism comes in the disguise of those things. What you have to do as clinician, when you see these symptoms persistently, you have to evaluate them and see whether it is Parkinsonism, because Parkinsonism is a treatable condition, whereas the others are not. We already know about the trap. We are not going to go much into that. And we also know that you have got the posture, the tremor, the muscle weakness, the mask-like face, and the stooping posture, the rigidity, tremor at rest, and shuffling gait, and all those things we have discussed. Now, we also know that Parkinsonism is a degeneration of the dopaminergic neurons in the substantia nigra. Substantia nigra has got two parts. What are they? Compacta and pars reticularis. Pars compacta is involved in Parkinsonism. Pars reticularis is important for emotional part of the moment, emotional moment. Suppose you have emotional moment. Pars reticularis is involved in that. Pars compacta is for the coordination and motor activity. So dopamine deficiency in nigrostriatal pathway impaired basal ganglion circuit. You know the striatum is, the substantia nigra is there. It is there below the thalamus. Actually, it is in the midbrain. And from this substantia nigra, there will be a projection to the striatum. What is striatum? Striatum is caudate nucleus plus putamen is called the striatum. So that projection is called the striatonigral pathway. The striatonigral pathway sends dopamine into the caudate nucleus and putamen into the striatum. There are two types of receptors are available, dopamine 1 and dopamine 2. Depending on the agonistic muscles through dopamine 1 are facilitated, the antagonistic muscles are inhibited so that the contraction is smooth and like a free flow, like a movement. Okay. The imbalance between the dopaminergic and cholinergic systems produces excess cholinergic movement, and tremor is nothing but the excess cholinergic activity. Excess cholinergic activity is the tremor. And you also see the mention of Lewy bodies. There is what is called Lewy body syndrome. What happens is there is one substance called synuclein, alpha-synuclein. When that accumulates in the basal ganglia, they are called the Lewy bodies. They may ask you, what is Lewy body? Lewy body is accumulation of alpha-synuclein in the basal ganglia. Okay. This slide last time we have seen, there is what is called the phenylalanine. Phenylalanine is an amino acid. It gets hydroxylated. One hydroxyl group is added here. That becomes tyrosine. That there is a phenylalanine to tyrosine is the first step. And tyrosine is again further hydroxylated to produce dihydroxyphenylalanine, which is also called the DOPA. There are two hydroxyl groups, dihydroxyphenylalanine. Here phenylalanine hydroxylase, here tyrosine hydroxylase. Then this carbonic acid group, COO double bond group, that will be removed. that is by dopa decarboxylase. Why am I knowing these things? Because my drug treatment involves this pathway. So there will be dopa decarboxylase, carboxylase inhibitors, phenylalanine accelerators, tyrosine hydroxylase accelerator, like that. So dopa decarboxylase removes the COO, and that becomes an amine that is called the dopamine. This dopamine is now beta hydroxylated to produce norepinephrine, which is further converted into epinephrine. And these are finally metabolized by the catechol O-methyl transferase, COMT. So, catechol O-methyl transferase is there in the blood. It is not in the brain. Okay, MOAB is there in the brain. Dopamine to norepinephrine, that can happen in the brain. But once it becomes norepinephrine and epinephrine and further catabolism, is not related to brain. That is related to the blood. Likewise, phenylalanine is in the blood. Phenylalanine to tyrosine and tyrosine to dopa occurs within the basal ganglia. So the phenylalanine crosses the blood-brain barrier, enters the substance of the substantia nigra compacta. There, phenylalanine hydroxylase catalyzes phenylalanine to tyrosine, further hydroxylated to dopa. And dopa decarboxylase removes the carbon dioxide CO2 group, the C double bond O group, from the dopa to become dopamine. That also occurs in the basal ganglia. So there are certain things which are occurring inside the blood-brain barrier, inside the brain, certain things which are occurring outside. That you can see here in this slide. So this is the hepatoencephalic barrier or the blood-brain barrier. Okay. So the L-dopa, you give as a drug, that L-dopa will get into this one, or from phenylalanine tyrosine is formed, tyrosine is going to become dopa will be becoming dopamine is secreted, in the vesicles are there, these vesicles come, they open up, and then dopamine receptors are there, D1 receptors and D2 receptors, and this dopamine is again enters into the synaptic vesicles here, and there is an enzyme called the MOB, monoamine oxidase B, which catabolizes the dopa. Suppose what happens? Dopamine is produced normally here, but MOB is inhibited, and what will happen? Dopamine levels will increase. In a patient with Parkinsonism, to increase the dopamine levels here at the receptor site, I can use a drug or MO inhibitor to prevent the catabolism within the brain itself. Understand? So we can prevent the catabolism within the brain, and after that, there is another reuptake is there. So there are the dopamine is again taken back by these vesicles, and that reuptake also can be prevented. Or this dopa outside can go to this dopa and dopamine. They can be decarboxylated. So I can prevent the decarboxylation by using a decarboxylase inhibitor. Or finally, when they become epinephrine and norepinephrine and that COMT pathway, I can prevent. So what are all the places I can interfere? I can use dopa decarboxylase inhibitor so that the decarboxylation is prevented and dopamine is there. Okay, or I can prevent MAO inhibitor, use MAO inhibitors to prevent catabolism of the dopamine. Or I can use reuptake inhibitors so that the reuptake into the synaptic vesicles is prevented. Or I can use COMT to prevent catabolism there, so that the dopamine is available in the precursors are available, and so much so the dopamine will be available in the system. So these are the various ways drugs are developed depending on the biochemistry there. Okay, now you can see here in this slide very clearly. So this is the blood-brain barrier. Okay. So where is this thing happening there? The COMT inhibitor, that is catechol O-methyl transferase, and DDC. DDC is that dopa decarboxylase. Dopa decarboxylase and COMT are two things which convert L-dopa to dopamine is facilitatory, and dopa to This one reduces the dopamine. What increases the dopamine? So whenever the L-dopa is more converted to dopamine by the DDC, then more dopamine is available. Or L-dopa destruction is prevented by the COMT, that also increases the dopamine. There are two ways I can act within the blood. What is that? I can increase the dopamine by facilitating the decarboxylase. Or I can prevent the COMT and prevent the catabolism, inhibit the COMT, prevent the catabolism, and enhance the L-dopa, which further converts into dopamine. Okay. Now, what are the drugs available? DDC, dopa decarboxylase, inhibitor drugs are there. These are benserazide and carbidopa. Benserazide and carbidopa are the two drugs which are dopa decarboxylase inhibitors. COMT inhibitors are entacapone and tolcapone. The capones are COMT inhibitors. Entacapone and these are the COMT drug inhibitor drugs. Entacapone and tolcapone. Dopa decarboxylase inhibitors are benserazide and carbidopa. Do you want to use benserazide and carbidopa or entacapone and tolcapone? Depends on whether it is a hyperkinetic disorder or a hypokinetic disorder. If you want to increase the dopamine, you will allow the dopa decarboxylase to act. If you want to decrease the dopamine, you can increase the dopamine also. You can prevent the degradation of the COMT. So, as far as inside, once it comes into the brain, this is the substantia nigra neuron. Their phenylalanine is there. Phenylalanine crosses here, becomes tyrosine. Tyrosine is 1-hydroxylated. That is further hydroxylated to form L-dopa. L-dopa again DDC is here and dopamine is formed. This dopamine is in the synaptic vesicles, and the synaptic vesicles open. When the dopamine is required, the synaptic vesicles are thrown open, and there is an enzyme called the dopamac, DOPAC, which degrades the. This is formed after the degradation of dopamine. DOPAC is formed, and MOA is the enzyme there. And there are drugs which act on the MOA. There are selegiline and reselagine. Reselagine and selegiline. So anything which is in blue is the enzyme. Anything with the green is a drug here. So how many drugs I have got? COMT inhibitors. DDC, dopa decarboxylase inhibitors. What are they? Entacapone, tolcapone. What are the DDC inhibitors? Benserazide and carbidopa. Carbidopa is usually combined with dopamine to give the synergistic effect. I will show you about that. And within that, we don't have much drugs here on the tyrosine hydroxylase or phenylalanine hydroxylase, but we have drugs on this DDC, which already we have seen. The catabolism of dopamine within the neuron can be prevented by monoamine oxidase inhibitor drugs, MOAB inhibitor drugs, selegiline and reselagine. Okay, once this is formed here, it can combine with DRD2, receptor 2 or receptor 1. There are drugs which block the dopamine receptor, the receptor 2, so much so the dopamine is more available for the receptor 1. So suppose there is dopamine here, I block the receptor 2, the pathway for the dopamine will be receptor 1. So the movement will be facilitated. Pramiperoxol and ropinol. Ropinol and pramiperoxol are another group. So how many drugs we have got? Now you say outside the blood-brain barrier, we have two. One is the COMT inhibitors. What are they? Entacapone and then tolcapone. COMT inhibitors. Okay, the top one. Below that, DDC inhibitors, benserazide and carbidopa. So once we come into the neuron, into the substantia nigra proper, I have MAO inhibitors, MAOB inhibitors. They are the selegiline and resergaline and selageline. Okay. Once it is released from the vesicles, I can block DRD2 and allow it to more act on the DRD1. They are the pramiprazole and ropinol. So these are the various. Why I am showing this? Because if you know the mechanism of action, you can use the drug correctly. Okay. So this is summarizing tyrosine to L-DOPA, L-DOPA to dopamine, DOPA decarboxylase, dopamine metabolism, and again the dopamine is MVAOB, that is DOPAC is formed, and then or it can go through the COMT through the 3-OMD. Therapeutic targets are DDC inhibitors, MAOB, and COMT inhibitors. This we have already seen. So L-DOPA crosses the blood-brain barrier, converted it to dopamine by the DDC. Carbidopa inhibits the peripheral DDC and increases its CNS availability. Improves bradykinia, rigidity, less effect on the tremor. Early use, start low, 100 by 25. That is, carbidopa is usually used as in combination with L-DOPA. L-DOPA plus this carbidopa together is available as Syndopa. It's available as Syndopa, 120 plus 25. It is used TID and slowly uptitrate the dosage. Adverse effects. Advanced disease, adjust the frequency, consider the sustained release formulation. Okay. Now, what are my therapeutic goals? Restore the dopaminergic neurotransmission. What is Parkinsonism? Parkinsonism is a deficiency in the dopamine, in the substantia nigra. So much so the movements are not free and not facilitated properly. There is rigidity, there is akinesia, there is bradykinesia. Akinesia, rigidity, bradykinesia are due to dopamine deficiency, whereas tremor is due to unopposed action of the cholinergic activity. If the dopamine is not there, dopamine is sympathetic amine. It is from epinephrine precursor. So sympathetic part is low, the parasympathetic part takes over, and that produces the tremor. Somebody may ask you, tremor is caused by in Parkinsonism. Don't say it is by dopamine deficiency. It is by cholinergic excess. Whereas akinesia, rigidity, bradykinesia, these are functions of the dopamine deficiency. Then you have postural instability. Postural instability is a combination. That is, D1 and D2 have to act synergistically to produce postural stability. When this particular function is disturbed, the D1, D2 synergism is lost. When that synergism is lost, you get the postural disturbances. So out of the four symptoms, akinesia, bradykinesia, and then these are, one more thing I told. Tremor is cholinergic, akinesia, bradykinesia, TRAP, T tremor, R is rigidity. Yeah. Rigidity, akinesia, bradykinesia are the functions of dopamine deficiency, whereas cholinergic excess is the cause for the tremor, cholinergic excess. Postural instability is because D1, D2 synergy is lost. Okay, you have to clearly understand what is producing what. So levodopa, this is the drug, this is something like a precursor of dopamine. Instead of body preparing the dopamine, we are giving in the tablet form. That is the levodopa, most effective symptomatic therapy, usually combined with carbidopa, peripheral dopa decarboxylase inhibitor. So this carbidopa is not acting within the neuron. It is a peripheral dopa decarboxylase inhibitor. Why? Carbidopa doesn't cross the blood-brain barrier. If it crosses the blood-brain barrier, it will go and act here. You can see here in this diagram. You can see here. Here, the DDC is here. This is within the neuron, and this is outside in the blood. This inhibits here. So much so, what happens? The L-DOPA, whatever little L-DOPA is there, it is available to go inside. So that is there, it facilitates. So it inhibits the peripheral conversion. Whereas here, this is not inhibited here. Okay. So L-DOPA to dopamine is prevented. So L-DOPA is available L-DOPA crosses inside. L-DOPA, this enzyme is available that gets converted to dope. This is the peripheral dopa decarboxylase inhibitor. It doesn't affect the neuron. Okay. That's why the diagram is essential for you. So, metabolic dopamine, this we have seen. What are the adverse effects? Suppose I use dopamine, what can I see the adverse effects? The opposite, the bradykinesia may be replaced by dyskinesia. Okay, motor fluctuations can occur. Patient may have hypotension. First dose hypotension is very common with the carbidopa, particularly when used dopamine and carbidopa. I have to be very careful about postural hypotension. So slowly step up the dose. Start with now 125 and slowly increase by 100 1/4 tablet. You can increase slowly. Okay. Now, dopamine agonists. So what are the dopamine agonists? This is a D2 and D2 and D3 receptor. D3 we have not talked. D1 and D2, make it as D1 and D2 receptors, independent of the neuronal storage. These are called pramipexole, ropinirole, rotigotine, apomorphine. These are the drugs which are the dopamine agonists. What are dopamine agonists? Those which increase the action of the dopamine. Their dopamine is reduced, but these drugs promote the action of the dopamine by making it available at the receptor. Useful in younger patients as add-on drugs for fluctuations, adverse effects or impulse control disorders, hallucinations, and edema can occur with these people, with these drugs. Then you have got the MOB. MOB, we know in the chart that it is within the neuron itself. It is the catabolic enzyme which degrades the dopamine into DOPCA, and that degradation is prevented. So much so dopamine is available more. So that way it acts. MAOB, monoamine oxidase B inhibitor. There is a big trial going on, DataTop trial. So these are two drugs are there: salicylic, resergiline, cephinamide. This new drug also has come, cephinamide. Usually salicylic and resergiline are used. So these are very mild in their action because they are trying to prevent the degradation of the dopamine, and they are not actually increasing the dopamine by increased synthesis, often used as early or adjunct drugs. What is the common side effect of this? Insomnia and then drug interactions. Monoamino oxidase is required for several drugs. So if you interfere with monoamino oxidase, drug interactions can occur, because monoamino oxidase is not only useful here, it is useful in some other drug metabolism. So drug interactions and insomnia are the two important causes. You should remember the side effects also. What are the side effects so far? L-DOPA. What is the side effect of L-DOPA? Dyskinesia, hypotension, nausea. Dyskinesia because overcorrecting. Excess dopamine causes dyskinesia, hypotension because it is a vasodilator, so dopamine. So naturally it produces hypotension. Okay, these are the two side effects. Always remember at least two important side effects. So next one is, if you have dopamine agonist, then you can have impulse control disorder, edema, and hallucinations are the side effects. If you use MAOB, insomnia and drug interactions can occur. And MAOB inhibitors are milder in action. Early disease or as an adjunct you can use. What is a powerful drug? Among these powerful drug, of course, is the L-DOPA. Okay. Dopamine antagonists also can be used. What are dopamine agonists? Dopamine agonists are two drugs, four drugs are there. Pramipexole, ropinirole, rotigotine, and apomorphine. Apomorphine is also now used in the treatment of this one. Then comes the COMT inhibitor. These are not within the neuron. COMT acts outside the neuron. It is in the periphery, block the peripheral COMT, prolong the levodopa halfway. peripheral degradation of whatever levodopa you have given, that goes into the blood, and that levodopa to retain there for longer time. You can use a COMT inhibitor also, so much so the levodopa given is available and that crosses into the brain, into the blood-brain barrier. What are the drugs available? Anticapanone, opicapanone, tolcapanone, all capanones, opicapanone, tolcapanone, anticapanone. This increase the levodopa half-life by inhibiting the peripheral destruction or conversion of the levodopa into further metabolites, useful for motor fluctuations, and adverse effects are diarrhea and hepatotoxicity. What I should do? Frequently monitor the LFTs, particularly with the tolcapanone. Okay. So now I am asking you a question. So first of all, levodopa. Where levodopa, how does it act? First it goes into the blood, and then it is a precursor of the dopamine. This levodopa crosses there, and it produces more dopamine. It works. What are the side effects? Levodopa side effects. Dyskinesia, mainly dyskinesia, hypotension. Okay. Now, the second one is dopamine agonists themselves. That means, those which facilitate dopamine to act on the receptors. We have nothing to do with the enzyme conversion there. And then those drugs are pramipexole, ropinirole, rotigotine, epomone. The problem is hallucinations, edema can occur. Okay, there is one drug called peripheral dopa decarboxylase inhibitor. What does it do? It peripherally blocks the conversion of given L-dopa into further steps. So L-dopa is increased, levels are increased, bioavailability is increased, half-life is increased, and that works there. That is called dopa decarboxylase inhibitor. What are the dopa decarboxylase inhibitor drug we are having? The most important one. What is the drug we are using? That is called carbidopa. Carbidopa and levodopa are combined and given as syndopa. So now, how does the COMT act? The MOABs act. MOABs are the catabolic hormone enzymes. Down from the dopamine, they catabolize it into DOPAC. DOPAC, DOPAC, and that step is prevented. Dopamine is more available. And what are the drugs? Selegiline, resegiline, safinamide. These are the three drugs. What is the side effect? Insomnia is the side effect. The insomnia is the side effect for the MAOB inhibitors, and of course drug interaction. Now you have got the COMT inhibitors. COMT drugs are, this is the COMT inhibitors are peripheral destruction of these hormones is prevented. It blocks the peripheral metabolism of these various neurotransmitters, and anticapanone, opicapanone, tolcapanone, these capanones are used there. The problem with them is hepatotoxicity and diarrhea. We have to monitor the LFT. Now, excess cholinergic activity is there. I can block the cholinergic activity by giving anticholinergic drugs. Because the tremor is a cholinergic activity. To control the tremor, the best drug would be an anticholinergic drug. What are the anticholinergic drugs? Trihexyphenidyl, benzitropine. These are the trihexyphenidyl is very commonly used. Trihexyphenidyl, what is the drug you use? Trihexyphenidyl. In your clinic, what is the brand name you use? Pacitan. You don't use that. So trihexyphenidyl and benztropine are the two important drugs. These block the muscarinic receptors. Okay, there are two types of receptors for acetylcholine. One is muscarinic, the other is nicotinic. So the muscarinic receptors are important for the basal ganglia, and these block the acetylcholine and correct the imbalance and produces dopamine acetylcholine. Balance is restored. What will be the side effects of anticholinergic drugs? Very common side effects. But dry mouth will be there, constipation will be there, cognitive impairment is there, particularly avoid in the elderly. Okay. Now, amantadine. Amantadine is MAO inhibitor, NMDA receptor antagonist with dopaminergic properties. In amantadine is antiviral drug originally. It is used as an antiviral drug. It is also useful for Parkinsonism, particularly useful for dyskinesias and mild symptomatic control. Libido reticularis, ankle edema, hallucinations can occur. Primary role is reduction of levodopa-induced dyskinesia. When you want to use amantadine, you want to get the rigidity reduced, but the dyskinesia you don't want. Then you combine levodopa and amantadine, the dyskinesia is reduced, rigidity is taken care of by that. Because the levodopa excess can produce rigidity. That rigidity can be prevented by the amantadine. Also helps tremor and rigidity to a mild extent. Mostly it will be useful for helping the levodopa to reduce the dyskinesias. Now, adenosine A2A antagonists. So these are the newer drugs, block A2A receptors in the indirect basal ganglia pathway, not the direct pathway. Indirect pathway, is inhibitory pathway. If you stop the indirect pathway, motor activity will be increased. Direct pathway is facilitatory, indirect pathway is inhibitory. D1 receptors are facilitatory, D2 receptors inhibitory. We already know that. So ATA receptor, indirect pathway is blocked, so much so motor activity is facilitated. What is the drug? Estradifilin. Estradifilin is the new drug, the adenosine A2A antagonist. Adjunct therapy for other drugs, well tolerated, very modest benefit, side effects are very minimal with this drug. Now, what is my management? Management of motor fluctuations. What are motor fluctuations? 1 week he will have hyperkinesia, dyskinesia. The other week he will have hypokinesia. So because this is a very tricky balance, Parkinson's a little bit excess, they produce dyskinesia. Little bit deficiency, the rigidity and akinesia is not. Many times we have patients who come to us with dyskinesia, and they're diagnosed as opposite of Parkinsonism, as dyskinesia. But my aunt, she was diagnosed as dyskinesia by a neurologist. But the problem is she was taking an anti-Parkinson drug, a Parkinsonism drug, to increase the levodopa. That is the one which produces the dyskinesia. So neurologist missed it. And he started giving some drug to treat the dyskinesia. That means to reduce the dopamine. Parkinson's already she is having low dopamine. She is giving drug to reduce the tetrabenzene. The drug used is tetrabenzene. Tetrabenzene he has given. Once he gives tetrabenzene, the whatever little dopamine is there is also not there. So the dyskinesia, she became totally rigid and hypokinetic now. So sometimes the dyskinesias may be due to over-treatment of Parkinsonism, either by levodopa or any of the other drugs. So you have to be very careful, go into the history. Sometimes it's very tricky to know whether it is a hypokinetic disorder or dyskinetic disorder. So one other lady of ours is there, she is in Hyderabad. She was diagnosed to be a dyskinetic disorder. We have put her on treatment. Our Santosh has prescribed tetrabenzene and baclofen for the dyskinesia, and she was in treatment. Some doctor in Hyderabad, no, these drugs are not good. You put her on levodopa. Yes, put the right opposite drug. Dyskinesia treatment is tetrabenzene and baclofen. And the treatment of Parkinsonism is levodopa, carbidopa, and selagelin and all that. He has put her on drug. She has become much worse. And she came running to me, no. Who said, who asked you to go to the doctor? So then they did some studies, a lot of neurochemistry studies are there. Ultimately, it was not Parkinsonism, but it is a dyskinetic disorder. So you have to be very careful whether you want to use tetrabenzene baclofen outside or levodopa and reselagine and other entacapone, those things. You have to be very careful. Non-motor symptoms. What are the non-motor symptoms of Parkinson's? This may be a short question. Depression may be there. How do you treat? SSRIs, SNRIs, avoid tricycles. Because tricycle, why I have a tricycle? Tricyclics are metabolized by monoamine oxidase. So I may use monoamine oxidase. I cannot give tricyclic antidepressants. What are tricyclic antidepressants? Tricyclic drugs. Amitriptyline, nortriptyline, those are the tricyclics. So for these people will have depression. And this depression should be treated with SSRIs or SNRIs, selective serotonin reuptake inhibitors, like that. Like sertraline, these are this group of drugs you can use. Psychosis, pimavanserin is a new drug, or quetiapine can be used. Orthostatic hypotension, midodrine or fludrocortisone can be used. REM, sleep behavior disorder, melatonin and clonazepam can be. This table gives, everything in one go. We have discussed so many things. I always have the habit of bringing them together and showing you in one go. What is that drug class? Levodopa. It is a dopamine precursor. It increases the dopamine levels in the neuron there, in the substantia nigra, more effective for motor symptoms, motor fluctuations, dyskinesias can occur. Okay, hypotension also, you can add hypotension can occur. Dopamine antagonist, direct stimulation of D2, D3 stimulation, less motor fluctuations, drug reactions and hallucinations. Okay, there are drug interactions can occur and hallucinations also. And MAO inhibitors inhibit dopamine breakdown, early disease benefit, modest efficacy. COMT inhibitors prolong the levodopa because the peripheral destruction is reduced, useful in wearing off. Diarrhea and hepatotoxicity are a problem. Frequent liver function monitoring is important. Amantadine, NMDA antagonist, it reduces the dyskinesias due to levodopa. You can add amantadine to reduce the dyskinesia. Levodopa will take care of rigidity and other symptoms, whereas amantadine can take care of the dyskinesia. Edema and hallucination can occur. Now, stepwise treatment. What is the stepwise treatment? Patient on levodopa with motor fluctuations. Step 1, optimize the levodopa dosage, frequency and formulation. Whether you are using short acting or long acting, but how frequently you are giving, 3 times normally, reduce the frequency, reduce the dose, or increase the dose. That is the step 1. Step 2 is add a COMT, that is catechol-O-methyl transferase inhibitor or MAO inhibitor. COMT acts outside the blood-brain barrier, MOAB acts inside the neuron there. Add dopamine agonist, or you can use any of the dopamine agonists. Finally, add COMT and then add dopamine agonist, and then amantadine for the dyskinesias. And lastly, consider apomorphine infusion, DBS, and then LCIG. We see those treatments there earlier. Now, management of motor fluctuations we have seen already. Now, in non-motor symptoms, this also we have seen. And then advanced and devices, these are the devices. DBS is deep brain stimulation. Substantia nigra globus pallidus interna stimulation. Why? Substantia nigra stimulation will produce an action of dopamine, and dopamine 1 goes and acts on the GPI through the caudate nucleus, and GPI is stimulated, that acts on the thalamus and again facilitates the movement. Either you can use deep brain stimulation of the substantia nigra or interna itself for refractory motor fluctuation. Levodopa, carbidopa, intestinal gel is available. So what it can do, it is a gel formulation. Levodopa, carbidopa gel is deposited in the GI tract, and it's a continuous dopamine delivery. So why are these fluctuations coming? Because when you give the drug, suddenly there will be motor fluctuations will be there because of the varying levels of the drugs that are taken and the frequency and other things. So if you have a continuous dopamine delivery, levodopa, carbidopa, intestinal gel, that's called the LCA. You can see that here. LICG, I have put it earlier. Okay, what is LCIG? LCIG is the gel I am telling. Okay, LCIG is the is levodopa carbidopa intestinal gel. LCIG, levodopa carbidopa intestinal gel. That can be used, or DBS, that is deep brain stimulation, or continuous epomorphin infusion for patients with unstable DBS. Okay. Now, is there any surgical treatment for that? Yes, there is stereotactic destruction of the thalamus and the pallidum. Okay. Deep brain stimulation of the thalamus and then internal segment of the pallidum, subthalamic nucleus, and then transplantation of the dopamine producing cells, embryonal cells. This is the stem cell transplantation. These are all experimental treatments, but of course, stereotactic destruction and deep brain stimulation are known procedures. Now, conclusions. Management must integrate motor and non-motor components. Mechanistic understanding guides drug selection. Titration must be individualized. Regular monitoring essential to balance efficacy and complication. Motor and non-motor symptoms must be addressed. Therapy must be individualized. These are the general principles. So with this, the treatment of Parkinsonism is over. Now we go to the other dyskinetic disorders. So.